Hispanic Americans do tend to suffer strokes at younger ages, and there is a higher incidence of stroke in that population, whichever type of stroke it may be.
Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 132 of the Strokecast. This week's episode is brought to you by the fine folks at Modus Nova. To see if Modus Nova can help you recover use of a hand or foot, visit strokecast.com/Modus Nova. It's late May right now as I'm recording this, and we are wrapping up another Stroke Awareness Month. Survivors, allies, professionals, and all sorts of folks across the U.S. have been encouraging folks to learn and understand the basic importance of BEFAST. BEFAST is the mnemonic device that English speakers can use to recognize most strokes. And considering that time is brain, it is so essential to be able to recognize a stroke early on and get to the appropriate place for treatment. In BEFAST, B is for sudden loss or change in balance. E is for sudden loss or change in eyesight or vision. F is for facial droop. A is for the inability to hold both arms up. S is for loss or slurring of speech or problems communicating or understanding language clearly. T means it is time to call an ambulance because any one of those symptoms can indicate a stroke, and getting treatment quickly is the key to saving a life and minimizing disabilities. So BEFAST: balance, eyes, face, arms, speech, time to call an ambulance. But what if you speak Spanish instead of English? As many folks in the United States and, of course, obviously around the world do. BEFAST doesn't directly translate well. So how can you recognize a stroke? PhD research scientist and EMS, or emergency medical services expert, Dr. Remle Crowe, and two of her colleagues worked on this problem over the past year. And they came up with a Spanish mnemonic, Ahora, A-H-O-R-A. Ahora translates to now, which is intended to capture the same sense of urgency that we have with BEFAST. This week, Remle and I talk about Ahora, the ethnic and racial disparities in stroke, and the metaphysics of tacos. So, ahora, let's meet Remle. So, Remle, thank you so much for joining us on the show this week.
Thank you, Bill. I'm excited to be here.
I first encountered you through my Google News alerts, looking at stroke news, about the development of Ahora, A-H-O-R-A, that you were one of the main folks behind. So can you tell us, what do we mean by Ahora?
Absolutely, yes. Ahora is a Spanish translation of the popular stroke screening instrument called BEFAST. And so BEFAST, of course, is this mnemonic to remember the signs and symptoms of stroke. And those are balance, eyes, face, arm, speech, time to call 911. And so ahora means now in Spanish, so preserving that, be quick kind of sentiment. And each of the letters in ahora stands for one of the signs or symptoms of a stroke that are included in the BEFAST tool, but using Spanish.
So let me interrupt here for just a moment. See, Remle and I went into this conversation with some base knowledge. We knew what we were going to be talking about. And I made the mistake of not actually asking her to explain that thing we both know. And it's kind of an important thing, because while we talked about ahora, we never actually talked about just what ahora means and how that mnemonic breaks down. So let's do that now. A is for andar. It refers to walking. Trouble walking can indicate a stroke. And of course, while I'm going through this, please forgive my poor Spanish pronunciation. It has been quite a long time. He pasado demasiados de años después que he aprendido alguno de español. And I probably screwed up that sentence too. Anyway, A is for andar. That refers to walking. Trouble walking can indicate a stroke. H is for hablar, the Spanish word meaning to speak. So trouble speaking or trouble with language can indicate a stroke. O is for ojos, or eyes. Trouble with vision can indicate a stroke. R is for rostro, or face. It refers to facial drooping, or in this case, also refers to a severe headache. A is for ambos brazos, or both arms. Does the person have trouble holding both arms up? Observing any of those symptoms, of course, means that it is time to call an ambulance ahora, now. Andar, hablar, ojos, rostro, ambos brazos, ahora. You can download a graphic of this at strokecast.com/ahora, AHORA. Ahora, regresamos a la conversación. You know, and that's one of those things that certainly jumps out at me. Plenty of Spanish teachers I can certainly recall calling out ahora at various points in class. And fortunately, they were not experiencing strokes at the time. How does ahora then differ from BEFAST? Because I understand it's not a strict letter-to-letter translation.
That's right. We did our best to include all of the signs and symptoms of the BEFAST, so they are definitely all in there. But I think one of the big differences in Ahora is that we also included a question regarding the worst headache of your life, or a headache unlike any previous headache. And we did this because it's one of the signs of hemorrhagic stroke, or a simpler way of saying that is brain bleed or a bleeding stroke. And so the existing tools in English are primarily focused on symptoms of ischemic strokes, or those that are caused by some kind of blockage in the brain vessels. But we felt that it was really important with Ahora to also consider hemorrhagic strokes, particularly with Spanish-speaking communities, as multiple studies have shown that Hispanic patients tend to be at higher risk for suffering a first bleeding stroke. And these strokes tend to also be more severe and debilitating than other types of stroke, and require care at a stroke center that's able to treat that kind of stroke.
Interesting. So, I mean, you know, it's really not that long ago that we were still talking about, even in English, it was just fast, face, arm, speech, and time. And it was due to some of the other getting input about some of the cerebellar strokes in particular, and some of the hemorrhagic stuff, that we started incorporating the balance and the eyesight in there. So, I mean, I know that's still working its way through. I think the American Heart Association is still just recommending fast. All the hospitals have migrated to BEFAST. And Ahora, it then appears to be even then more comprehensive to reflect that added element of the hemorrhagic strokes.
Yep, that's right.
Well, I think that's also really interesting when you talk about Hispanic folks having a higher incidence of hemorrhagic stroke versus ischemic. Do we have information about why that is?
So there's a lot of reasons behind that. Obviously, higher rates of stroke risk factors are something really important to take into consideration. We hear about high blood pressure as one of the big ones. High cholesterol, diabetes, obesity are some other risk factors. And often these factors go untreated in Spanish-speaking populations, and there are a variety of reasons for that, as you might think. Limited access to healthcare. And so all of these social determinants of health have relationships with health risk factors. Language is certainly one of the important social determinants of health. And so not only are we seeing higher rates of hemorrhagic stroke in these populations, but when it comes to stroke awareness, and we know that recognizing a stroke early is a key to having a good outcome, but there's been a number of studies showing that differences between Spanish-speaking Hispanic Americans compared to English-speaking Hispanic Americans and those who speak Spanish were far less likely to correctly identify the signs and symptoms of stroke. So this is a huge part of, why we wanted to share Ahora and help this population understand signs and symptoms of both types of stroke, so whether that be ischemic or hemorrhagic.
So we're seeing seeing a difference then in awareness based on Spanish speaking versus English speaking. I know a lot of those things that you just mentioned about some of the probable risk factors that Hispanic folks are facing sound similar to some of the conversations we've heard about the challenges African Americans are facing as well. I don't know if you have any research or information, but do you see a larger incidence of hemorrhagic versus ischemic strokes in African Americans or other ethnic or minority groups?
Yes, that's absolutely right. So these social determinants don't just affect one group, and we do see higher rates of hemorrhagic stroke and also at younger ages in the African American or Black population in the US. And again, this is just such a complex web. It's hard to pinpoint just one cause, but these are multifactorial things that we have to address together in order to create this kind of change.
So when we're talking about a lot of those changes or those impacts, then it sounds like what you're also seeing is that they are then culturally or artificially driven. There's nothing necessarily inherent in genetics or biological differences that are associated with skin color or coming from different parts of the world. Like, for example, we see a higher incidence of moyamoya disease in folks of Japanese descent.
Oof, you have made my epidemiologist heart so happy. That is the best question. Yeah, this is such an important point when we're looking at research, looking at, health disparities, and we saw this with COVID-19 too. So we see higher rates of a disease in a population, and we're really quick to want to draw that causal or that biological link. And that's not what the data are saying at all. You're absolutely correct that, especially things like stroke and heart attack and these risk factors are more socially determined rather than some kind of biological mechanism. So things like access to healthy food, access to transportation, whether there's food deserts, access to healthcare, these are the social determinants of health that are disproportionately affecting people of color compared to white people living in the US.
And I think that's probably also then, and if folks still aren't sure about that, I think that's one of those things that we start to see, even among white people, we start to see much higher impacts of stroke and other diseases in communities, in the stroke belt in the U.S., in some of the Appalachian communities, and some of those parts of those communities that do have a larger percentage of white folks, but are also facing some similar societal challenges and are then encountering higher stroke risk as well.
Absolutely. Geographic isolation, as well as some of those socioeconomic indicators, can play a huge role in your access to things like healthy food and a healthy lifestyle. And then, of course, being able to access things like preventative healthcare.
So what that also then means that these are all things that we as a society can fix with enough time, resources, and willingness.
Absolutely. Just those three things.
Yes, those three things, just those little details. Yeah. Can we just totally upend the way society works? That'd be great. Thanks.
Yeah,
So, I mean, what was it that particularly inspired you to pursue this initiative and to drive the creation of Ahora?
I can say without a doubt, the driving force between this initiative happening at this time was definitely my friend Marisela Wilson, or Marcy. She's a stroke community outreach coordinator here at Seton Hospital System in Austin, Texas. And so Marcy had partnered up with another friend of mine who is a physician and an EMS medical director, Dr. Paul Banerjee. And they were testing out some translations that they had been working on. And they started off actually with rápido because it means fast in Spanish. And so clearly it's a close translation. But they weren't able to make the symptoms align perfectly with those letters. And they called me in to brainstorm with them. And I was like, yeah, how can it be that this doesn't exist? All right. So after many iterations and many sticky notes, we came up with Ahora, which, it does possess more of those favorable memory aid characteristics. And having lived in Mexico City and gone through my EMS training there at the Mexican Red Cross, it was just so surprising that there wasn't that quick and easy mnemonic for stroke in the US. And so we really wanted this initiative to go forth. And Marcy has interviewed countless patients who have suffered stroke. And one of the things that always stood out to her was this lack of awareness or way of recognizing that a stroke was happening. And obviously that's key for also preventing a second stroke later on.
So it was then in part so driven by the lack of an existing mnemonic combined with probably, living in Texas and seeing a need, and then also your own connection with Mexico City.
Absolutely.
It's amazing how all these different threads of our lives can come together in one particular place.
It really is.
Just to go back to the some of the differences in stroke rates for a moment, do you see any differences, or we see these differences with Hispanic folks who are more likely to suffer a hemorrhagic stroke or higher rates of stroke. Do you see that persisting in second and third generation Hispanic and Latin American immigrants, or is it primarily just in folks who have immigrated and maybe their immediate children? Do these differences dissipate as families have been in the United States for multiple generations?
And that's a really great question as well. So it's also a hard question to answer, although there have been some studies specifically looking at Mexican American families. And it's actually interesting that there's evidence that Hispanic people who are born in other countries have slightly lower risk of stroke than Hispanic Americans who were born in the United States. And in this study of Mexican Americans living in the United States, those differences did persist to even second or third generation. There hasn't been a ton of data around this, so I hesitate to cite one study, but we can see where a lot of maybe some of the social determinants can get addressed, like the language barriers may get reduced, but there's still so many other socioeconomic and social factors that we do see these differences. And it's not just in hemorrhagic stroke. There's also a difference in ischemic stroke. So Hispanic Americans do tend to suffer strokes at younger ages, and there is a higher incidence of stroke in that population, whichever type of stroke it may be.
And of course, once you get beyond third generation, then we're starting to track back to families that immigrated upwards of 100 years ago. And by the time you're hitting fourth generation and whatnot, you've also got a lot more cross-race marriage and mixing, and which is going to complicate the details for any particular study.
Absolutely. And again, I think it goes back to not necessarily there being this biological link, but just a link of how you're living in community in the United States as a Hispanic American.
With the focusing then on the Ahora messaging, obviously from your background, it's primarily designed around the Spanish-speaking population of the U.S. Do you expect to see this in Spain or Mexico or Central or South America as well? Or do you have initiatives around driving that? Or is it really just let's focus on the U.S. for now and help other organizations sort of take up the banner if they choose to?
This is a great question. There was a ton of debate among the team as we were doing this because Marcy also is from Mexico, and I lived in Mexico City, where there's a very distinct Spanish. So we purposely tried to take a very neutral Spanish. And we actually asked around with friends from different countries, from Puerto Rico, from Spain, from Chile, to try to come up with a tool that we could maximize dissemination with. So we did our best to try to stay neutral in the Spanish that we used. An important thing here is this was our pandemic hobby. So we aren't trying to keep rights to this or anything. We've made the tool part of the Creative Commons. So our hope is that it's going to get adapted for local needs in other settings, and that people will continue to help Ahora evolve to reach the most people possible.
Other people were baking sourdough bread and growing sourdough cultures, and you're just busy trying to save millions of lives around the world.
Well, I've never been much of a baker.
When you talk about you trying to use a standardized sort of Spanish, I think that's one thing a lot of folks don't necessarily realize is that Spanish is very different in different countries and different parts of the world, just as is the English spoken in Seattle is going to differ from the English spoken in Dublin, in New South Wales, and in other places, everything from dialect and pronunciation to specific vocabulary and word choice. I know in a recent interview, somebody was with somebody in Australia. They were talking about their national disablement insurance scheme, I believe is what it's called, had to clarify that scheme is just a general use for plan in other parts of the world. In the U.S., it has a specific negative connotation. So there's a lot of very complex parts that go along with that. That said, given that you went with standard Spanish or tried to standardize it, keep it as simple as possible, how closely does that align with the Portuguese spoken in Brazil, another huge country? And Spanish and Portuguese are, of course, very different languages, but they are similar in many respects.
That's a great question. And I speak French and Spanish, so I'm able to read a little Portuguese, but I'll say that the spelling is different. So I don't know that it would carry over in terms of spelling. And if the word aorta is now in Portuguese, I don't know. But I think it's certainly another area where I would be surprised if there was a stroke mnemonic, and definitely something I would hope gets developed if it doesn't already exist.
And perhaps it'll inspire a Brazilian Portuguese speaker to go ahead and develop one for that community if there isn't already.
Hopefully there's one listening, yes.
I mean, your role in all this is great. And like you say, you talk about this is a pandemic hobby. It's not exactly your day job. I mean, it's inspired by a lot of the work that you've done in your career, but your actual job is a research scientist. And so what does that mean? What do you do as a research scientist?
That's a great question, too. Well, I think the short answer on that is that I use data to answer questions. And particularly, I'm focused on questions that improve community health and safety. So I work at one of the large suppliers for electronic medical records software for EMS or emergency medical services. And we have this huge research database of de-identified data, so we could never pick out which patients were which or anything like that. But we use this big database to help improve out-of-hospital care. So a lot of that obviously has to do with stroke screening, and there's just so many research questions. But I'm very fortunate in that I don't have to do all the research myself. I get to work with researchers all around the country, even internationally. And so we design these studies. Often I end up performing the statistical analysis. So yes, in case I've been able to hide it thus far, which I suspect I probably haven't, I am a huge numbers nerd, and a large part of my life is looking at numbers and trying to help us improve health.
So you may be working at with tools of a different scale, but it sounds like you're going to then be very familiar with my favorite video game in the world, which is Excel.
Yes, I play that game often, but I have upgraded to Stata.
Ah. Impressive. I'm in my work life. I'm actually starting to play a little bit with Power BI and data visualization there, and figuring out how I can really screw up my messaging that way.
I think that's a really important message.
But I mean, I know just as a side thing, one of the things I really like about working with numbers and working with spreadsheets is that at a certain point, you get it right or you get it wrong. The formulas work or they don't.
More often than not, they don't.
Exactly. But yes or no, unlike those squishy wetware issues that are people.
Yeah, I know, people.
So being this huge data nerd, which is awesome. I mean, you've got this background. We've already talked about you did EMS in Mexico. You're working with research software and data analysis on patients' conditions now. You're working in linguistic mnemonic issues with Ahora. You've been working with Ford. I mean, how does all of these different fields and threads, how do they all come together? So Remle, what I'm asking is, how does your career make any sense?
I don't know that it does, but it's been a fun ride, that's for sure. I think I'm definitely a believer in things happen for a reason. So all of this came together. I was studying abroad in Mexico City during my undergrad, which was in business administration. And so during my last month there, I was actually in a car crash. I was not injured, but I was fortunate enough to ride in an ambulance. And then that's kind of where it clicked for me. Hey, this is what I want to do with my life. So I finished up business school. 6 months later, I moved back to Mexico City, much to the chagrin of my mother. And I enrolled in EMT school with the Mexican Red Cross. And then, of course, I needed that day job to support my volunteer EMS habit. So through a friend, I ended up finding a job at Ford of Mexico. And they quickly moved me around positions and decided I was going to be a clutch engineer. And I got trained in improvement science. So maybe you've heard about Six Sigma and Black Belt. But this was the first place where I got to use data to solve problems all day long. And it was just awesome. And so when the opportunity came for me to pursue a research fellowship in EMS, specifically in Ohio, I kind of just knew, all right, that's the next place of the path for me. So I've now finished that fellowship and completed my PhD in epidemiology, and I consider myself beyond fortunate to have landed at a job where I get to do EMS, research, and improvement science all together. So I'm really blending all of my passions here at this place.
That's amazing. And there's a few things I want to unpack about that a little bit. First of all, what can you tell us about the EMS space or the field in Mexico? I mean, I think especially a lot of Americans have very limited perception of what emergency medical care looks like in Mexico, outside of sort of what we hear on the news, which generally is not good. And lot of folks don't quite realize Mexico City is it still the largest city in the world?
I think it just depends on how you count that. So as a numbers nerd, I'm sure I could make it the largest city in the world if you like. True statistician here for you.
Sure.
But yeah, it's an interesting world of pre-hospital care in Mexico, and in particular Mexico City. So I always said, why would you go study EMS in Mexico? Well, if you want to get really good at something really fast, why don't I go to a city of 26 million people where on a good night there are 6 ambulances out, and sometimes the ambulance doesn't really have all the equipment, so it's exciting. You have to improvise and you have to really know your stuff. And I say that with my whole heart, that EMT school here in the US tends to be maybe a semester, maybe a trimester, but in Mexico, it was a true academy setting. It was a year-long course, and you had to try out to get into that course. They interviewed me 2 or 3 times thinking I was totally nuts, and I was. And so, reporting Saturday and Sunday, paying to go to school so that I could be a volunteer EMT. And then of the 50 of us in my class that went in, 9 of us graduated. It was an extremely rigorous year, and the end of course testing is quite comparable to what we would do here with, the skills sessions as well as the written exam, because once you graduate, you're really the person out there making the decision, and your decision could truly impact somebody's life.
Wow, that's amazing, and that scale alone, 6 ambulances on a good night in a city of 26 million. I think we probably have 6 running on a bad night in Seattle on a city of 500,000.
Oh, I'm sure you have many more than 6.
Yeah.
And I mean, to put things in perspective, a lot of EMS professionals here, might intubate once or twice a year where they're placing a tube in somebody's throat to help them breathe. That was happening for me on a shift, once or twice a shift. So my first ever shift as a student, still being in that precepting phase, I responded to 2 cardiac arrests where we performed CPR, and one of those patients lived. So it wasn't just something that I would see on the TV.
Wow.
I was like, wow, this actually works.
Wow. Yeah, and you do a lot. You do a lot of the thing. You get really good at it really fast.
Yeah, I think I saw in 4 years what I may not have seen in a career in some places.
So the other thing that's really then interesting there too is your focus on research in EMS. I think a lot of folks don't even think about there's a huge research component in the data analytics of what EMS does. And it's not just looking at the studies of which alone have been fascinating about, how do survival rates compare when an ambulance travels with lights and sirens versus running without sirens and whatnot. And the time, whether or not it actually saves any time. And that stuff has been fascinating.
Right.
But what's the other type of stuff you look at in research in the EMS space?
Oh, so there's so much to that. And one that you mentioned, that's a huge part of community safety, right? Running with the lights and sirens on is a dangerous intervention. So we have to make sure that it's worth using, especially now with cars and soundproofing. When an ambulance pulls up behind you, it scares you. And I know that because I've been driving the ambulance before when it scares people. So it causes people to make bad decisions and to move out of the way, possibly into the way of another vehicle. So that poses a risk to the community, as well as obviously it's stressful for the patient to hear. So these are, important safety questions to recognize. Another key aspect is the workforce itself. So you may have heard reports in the news about, these violent acts towards EMS professionals, towards healthcare workers in the emergency room. All of these things are really important to research as well. Things like burnout with COVID-19, we're definitely seeing that kind of fatigue. I could go on and on about all of the things that we're seeing in terms of the mental well-being of our workforce, but that's definitely something to keep researching. And then, of course, there's the direct clinical care. So are the interventions that we're doing in the out-of-hospital setting the right ones? Are we making a difference in a patient's outcome? And that's a lot of what I do right now. So I've looked at things that predict a patient's outcome, so certain acuity scores. I've looked at, there are a million stroke scales, so especially when you get into the healthcare setting, it's not just FAST. There's RACE, LAMS, VAN, you name it. I could probably come up with an acronym for it. But do any of those really perform better than the simple face-arm speech? And the answer that we found with 13,000 EMS encounters was that face-arm speech works just fine. So that's something simple to remember. We can do it and we can make a difference with it. But I think it's interesting that a lot of research in pre-hospital care has come from, the hospital setting. Well, it works in the hospital, so surely it'll work in this uncontrolled environment on the side of the road in the middle of the night in the rain, or going down the highway at 40 miles an hour, avoiding those Ohio potholes. So I think it's really important, to test the research where it's being conducted. One of my favorite randomized control trials was looking at parachute use. Now, I don't know if you've read this one, but essentially—
No, I have not.
Oh, this one's a great one. So they tested, jumping out of a plane with and without a parachute. Does it make a difference? Well, what would you expect?
I would hope that it makes a difference. I would imagine it's, once you get above a certain altitude, maybe it doesn't when you start factoring in terminal velocity. But yeah, no, I do not know.
Well, you know what they found out? This was randomized control trial, the gold standard of research. They found out that parachute didn't make any difference. They had some people jumping out with backpacks full of nothing, and they had some people jumping out of the plane with a backpack full of a parachute. It made absolutely no difference in injuries or deaths. The key: setting. The aircraft was on the ground.
Okay.
So that obviously has no application to the real world where you'd be using a parachute. So why would we do that with, pre-hospital and EMS care? We've got to test it in the setting where things are happening. And so that's a huge part of what I help do with this research data set.
I was going to say in the sky, that would be a heck of a time to find out whether you're in the control of the experiment.
Yeah, I don't think I would have signed up for that one. I love research, but count me out.
So yeah, you actually have to get out there and see what's going on. How do you do that research then in that chaotic environment and try to get something that resembles duplicatable results?
Yeah, it's actually quite difficult. A lot of our research is dependent on just what we call observational data. So these are data that got collected for different purposes. In EMS, we're really lucky. There's a data standard called NEMSIS, the National EMS Information System, and it's a standardized list of data elements that get collected no matter where you are in the country. So in Seattle, they're collecting the same data elements as they are in Texas, as they are in, New England. So we're able to.
So in terms of those data elements, then are we talking about like patient specs, like age, gender, observed gender, BP, blood sugar, etc., or is it more time to ambulance, initial diagnosis, accuracy of diagnostics, time to hospital, that sort of stuff?
So all of the above. Definitely, it started off when we're talking about performance measures in EMS, we'll be talking about response times, which there's actually very few conditions where an extra minute or two are going to matter. So the reason response times were so popular, it was something easy to measure. Now, of course, response times can be really important. That's something we keep an eye on, but we started to think
it's a politically sensitive measure too. When you can be in a community and say that, our response time is 6 minutes and 15 seconds versus 7 minutes, 45 seconds.
And if you're the person on the other side of 911, minutes can feel like hours. And so I certainly empathize with, I call and I would like somebody there as soon as possible if it's my emergency. Absolutely.
Right.
But there's a lot of other data elements that we need. So, are EMS professionals recognizing the stroke and taking the patient to the appropriate facility? That's a question we can answer with our data because we're collecting the EMS provider's field diagnosis. We're collecting vital signs at the time of care. All of the treatments performed, we collect those in a standardized manner. And then, of course, you have your patient notes and your narrative. And so there's all these new technologies like natural language processing and machine learning that can help us kind of dissect some of those notes and look for clues.
And that's all that stuff is really important because obviously once you get to the ER with your experiencing a stroke and the EMS is reported ahead that, yes, this is likely a stroke, you're going straight in versus triage and taking somebody to the wrong hospital. Sure, you could, maybe it's 15-minute less travel in the ambulance, but if they're at the wrong hospital, that's going to add probably an hour and a half to their treatment time to get them to the right hospital and transferred and all of that stuff. Much easier to do it right the first time.
Right. Absolutely. Add the time to get imaged and then to get you back out the door and transported to another facility. That definitely can add some time. And particularly in settings where there are appropriate facilities nearby. Obviously, triage and transport destinations are complex decisions, but EMS can really play an important role in that early recognition. And there's this anchoring bias, right? So if you come in and you're saying, that person has a headache, well, they might sit around in the hallway for a while versus getting imaged immediately. If you're like, I think this person is having a TIA or having a stroke, then, like you said, they're more likely to get imaged more quickly.
And is there, what we're starting to see is more of the deployment of specific mobile stroke units in cities around the country. Are they available in significant number at this point to start getting data about the impact on care, or is it still just sort of too new and too small?
They're kind of few and far apart right now, and it's a question of, do the cost outweigh the benefits? So you can imagine where something like that might be most useful tends to be rural settings, but positioning that vehicle to get there any faster is always a challenge. So the research on those are still pretty new, and we're still figuring out, well, are these useful? And if so, where? It's not this one size fits all model where, we're going to send that mobile stroke unit everywhere. Probably just would not be efficient, particularly in urban settings where your ground EMS transport times are not as long. I mean, if I had it my way, we would just deliver something by drone, do some imaging. I think we'll be seeing more drones in the future.
Well, I wouldn't be too surprised, actually. I mean, from a conversation I had with a team in Australia that's developing an actual mobile CT scanner that can be outfitted directly into an ambulance or even into a small aircraft, allowing in Australia they could then complete the CT scan in the aircraft before the aircraft takes off with the patient to dramatically reduce times. Had another guest on, Dr. Aaron Stamen, who's an expert in transcranial Doppler ultrasound.
Wow.
Where they actually use an ultrasound wand like we may have seen in when they looked at our hearts for PFOs, or that they use to look at fetuses and development. They can actually hold that wand up to the eye socket or the temple or the back of the head where the bone is thinnest and actually get imaging of live blood flow in the brain. They're now talking about developing caps that can then put on a person's head and start capturing imagery of live blood flow in transport, in a helicopter.
Yeah, I remember at a conference not too long ago seeing a kind of helmet device that could look and see blood flow. I think it was some sort of EEG. So definitely the future's coming. I'm waiting for the app so I can download it. I'm sure it'll be here soon enough.
Oh, sure. All that stuff is coming. But when we joke about drones providing that kind of care, we're not that far off from something in that space.
Oh no, and in EMS, actually, drones are under investigation right now. I mentioned that I've been doing Journal Club, and we just reviewed a study out of Canada looking how to optimize drones for delivering AEDs, which is a defibrillator. So when your heart stops, you need an AED as soon as possible. And a lot of times those occur in homes. So, you go to the airport, you see one every 5 feet, but when cardiac arrests are occurring in homes, you need a defibrillator quick. So they're looking at how can we leverage drones to get them to the right place at the right time.
And that makes sense when you've got equipment that an individual can use that you don't necessarily have to have an EMT to use. You can deliver that via drone while the ambulance is still waiting in traffic.
Yep, absolutely. And it can beat them by more than a few moments. And then you, of course, have your dispatcher who can give instructions on how to perform CPR and stay on the line with that person.
So with all of this really cool stuff happening, what's sort of the technology in EMS and the space that you're most excited about over the next 5 years?
I think there are quite a few innovations that I'm pretty excited about. I'm mostly excited about technology that helps us be better upstreamists. So I'm not sure if you've heard that term or if you know the term.
I haven't. What's an upstreamist?
So basically it's about prevention. So there's this parable that goes, 3 hikers came up on a stream and they noticed that there's a ton of children in the water and they're all drowning. And so 2 of the 3 hikers immediately jump in the water and start swimming the kids to shore one by one. And the other hiker marches off along the riverbank. And the other 2 are like, hey, what are you doing? Where are you going? They're all drowning. And she's like, well, I'm going to go find out what's throwing them in the water. So it's about going upstream and addressing things like social determinants of health and how to prevent illnesses. So I think technology has the potential to help us close some of the disparities we're seeing in medical care, which is just key. And you mentioned like isolated geographic regions like Appalachia. I think that things like telehealth are going to help us be able to reach populations who have been isolated or left out, whether that's geography, whether that's poverty, whether that's a language. I'm excited to see how these tools get leveraged to help more patients far and wide. And obviously, I'm hyper focused on healthcare. A quote that I heard probably early in life that I just love is, "If you have your health, you've got 1,000 dreams. But when you don't have your health, you've got just one."
Mm. Yeah, that makes a lot of sense. So, what's interesting is that then that's sort of your focus and things that really are exciting for you in this space as an EMS researcher are finding ways to make it so that EMS doesn't have to go out and take care of stuff.
I know, I'm trying to put myself out of a job. The worst EMS professional ever. No, but I do think that's important. And it's neat to see how EMS is getting integrated into the healthcare continuum. So, when I was working in Mexico City, I would drop my patient off at the door and then never know what happened to them. Now, at the company where I work, we're figuring out how to link records throughout the continuum of that visit so that, I can find out, hey, did I help that patient when I recognized their stroke? Was I right? Did they get the care they needed? So that's another exciting aspect that's hopefully going to lead to a lot of job satisfaction among EMS professionals, so we can see how our work makes a difference.
I know I've talked with survivors who've gone back and actually tracked down the EMS folks and the helicopter transport folks who took care of them in that first initial period. And the impact on being able to go visit those folks, it's just so powerful on the EMTs to see this person walking or talking or even just still alive and not actively bleeding in front of them.
Oh, that's huge. I mean, we see so many things that have bad outcomes. To get some of that positive feedback or see where something worked out well, those are always the more meaningful things to me. And oftentimes it's little things I did that I didn't even know I did that had such a big impact on somebody. So some of the thank you notes, I'm like, wow, that was really what mattered to them. So I think that that's just huge to have that follow up and be able to reunite with some patients.
Absolutely, and make it easier for the patient to figure out how to make that connection too. Yeah. I mean, I think one of the criticisms a lot of survivors have about the hospitals and the doctors that they talk to is that there's still this perception that all your recovery happens in 6 months and then you're done and you don't recover after that. And I think part of that perception, which fortunately we're starting to see a little bit less of it, is that the doctors and the OTs and the PTs that we see inpatient only see us at our absolute worst to the point where we can survive outside. They don't get a chance to see us thriving and continuing along that recovery. And if you don't stay in touch with those folks, they're not going to see where you end up and where you go and how well you can do. And so that's going to skewer their perception a little bit. So not only is it good to go back and see those folks just to make them smile, but also to help other survivors.
Oh, absolutely. And, I wonder in EMS, sometimes we have these events where we invite cardiac arrest survivors back to tell their stories. I would think that would be a valuable experience for stroke survivors and their caregivers as well.
Absolutely. There's always a ton of value in telling your story for yourself and for the people who can hear it. It's in telling your story, you sometimes learn your story a lot better. So obviously, world's turned upside down in the past year as we're
something going on.
Yeah, a little bit. I think we're currently at what is today, March 415th or something like that.
Yeah, sounds about right.
So aside from giving you the time to come up with Ahora, how else has COVID-19 impacted the work that you're doing?
Well, first of all, I know that I am absolutely incredibly fortunate to be working from home and not have my work life disrupted as much. So, I mean, beyond the usual, I'm eating way too many tacos and running out of Netflix to watch. I could say that in my work life, COVID-19 has certainly shifted a lot of my research priorities. For example, early in the pandemic, one important area of focus was people were pretty hesitant to seek care because they were afraid of contracting the virus. So in EMS data, we started to see a lower number of calls to 911 overall. And then, even more interestingly, perhaps, was that there were higher rates of people who were not going to the hospital after calling EMS. And this goes across the board for things that appear to be time sensitive, like a stroke or a heart attack. And then, I further dug into these data and I found the differences aren't exactly across the board in terms of demographic characteristics. So we saw lower rates of EMS transport among patients who were Hispanic, as well as patients who were Black or African American. Also saw lower rates among women. So we said, hey, these are some really important trends for EMS agencies to monitor, and we got to think about, we call it the affective domain. How do we communicate with patients who are, one, experiencing an emergency, which is scary enough, and then during a pandemic, and so you're actually fearful of going to the setting where you can get help.
Interesting to see those disparities come up even further. So basically it was white guys were still happy to go to the hospital.
Less happy, but happier than other folks. All transport rates went down overall, which was interesting. So one of the first things we did in the pandemic was we have this big data set. Let's use it for surveillance. Let's put the epidemiology to work. And we started to monitor call volumes and just call volumes among certain patient presentations. So, chest pain calls fell. There's no reason for, why would that happen? Okay, well, all right. Now let's take a look within demographics. And that's what we started to see across the board. Volumes have since picked back up, but this is something that persists and that we need to continue to monitor as part of our normal ongoing surveillance of our data.
That's fascinating. Why do you think those differences were exacerbated among different ethnic communities?
I think, again, there's a number of reasons, and distrust of healthcare profession is an important part of this. It's also thinking about the demographics of the EMS workforce is important. So, by and large, EMS is composed of majority white males, and so there's a lot of data around having a diverse workforce helps us be more better off, and we have a better communication toolkit. So I know this is a touchy topic, and I've researched it, I've spoke about it a lot. It's really important to kill some of those myths that are out there. So, talking about diversity in the workforce doesn't mean that, the female provider always responds to the female patient, or the Hispanic provider always responds to the Hispanic patient. No, what it says is by having a more diverse workforce, there's a chance that I have worked with somebody who's different than me, and I've learned from them watching their care. And so we're all better off together. Our toolkits are a bit more robust. So I do think that encouraging diversity in the EMS workforce is key to helping some of these disparities. And we've seen it in other settings in the hospital. So definitely another area for future research investigation.
Absolutely. And you said something else there that didn't make any sense to me whatsoever. You used the phrase eating too many tacos. I understand each of those individual words, but I don't understand them all strung together like that.
I mean, people have told me these words. I don't really pay any mind to them. I haven't hit that level, I guess.
So, I mean, obviously, you've done all this research. You've got this background in this detailed statistical analysis. You have all these data sets. I'm sure you've created your own data sets. You have all these statistical tools available. So how do you make the best tacos?
Well, we've talked about my sourdough starter, or lack thereof, so I'm going to tell you the truth. I usually just take that short walk down the street to the taco truck. Though I will say, with the pandemic, I have more hobbies. I've been messing around a bit more in the cocina. There's YouTube is a good friend. I know that the key components to a good taco are for sure in the salsa. The spicier, the better. Definitely the tortilla. There's no such thing as a crunchy taco with orange cheese in Mexico. So you're going to want, a corn or homemade flour tortilla. And in Texas, I am totally and utterly spoiled. We've got our H-E-B grocery store here. So you can buy one fresh made tortillas on site, or my favorite, you can buy halfway made tortillas. You put them in the fridge, and then when you're ready to finish cooking them, throw them on the griddle and you're good to go. So, but if you're interested in actual, Mexican cooking, Casa Jauja on YouTube is definitely a great place to get started. Learn Spanish, learn cooking, all at the same time.
Absolutely. We'll definitely have to link to that in the show notes.
Oh, show notes for sure.
How do you get, so how would you compare the tacos you can get in Austin versus those you were able to get in Mexico City?
So definitely different. There are clearly authentic Mexican places here. And it's funny because they call them, when you're going to a Mexican restaurant, somebody here will always specify, oh, you want interior or you want Tex-Mex? And when they say interior, they mean Mexican tacos. And I'm like, okay, that sounds great. But there's definitely some interesting ones here. I've had Indian food in a taco. I've had a jalapeno sausage in a taco. Torchy's is definitely a Texas favorite. Highly recommend if you come to visit.
Awesome. So is if you put your assorted ingredients then into a taco shell, does that automatically make it a taco? Or what is required in order for it to be a taco?
I think if you believe it, it can be a taco. Yeah, I mean, what can't you put in a tortilla that doesn't get better when it's in a tortilla? That's what I want to know. I mean, I've done the trifecta. You can have breakfast tacos, lunch tacos, and dinner tacos, and they can all be very different here in Austin.
That is fantastic. I think we've learned some very important things here.
The record is 6 meals in a row. I think that's key.
Nice. That is something to aspire to. I will say in terms of non-taco tacos, the Taco Bell tacos are surprisingly fridge stable. I mean, you could throw those in the refrigerator.
Yeah, but you don't actually own those. You rent them. Come on.
Yeah, very true. Very true. And having consumed enough of those, that may very well be why I ended up having a show like this anyway.
Yeah, well, in that case, more power to it. They should pay for the show.
Yeah, there we go. Remle, this has been absolutely fantastic. If folks want to know more about you and what you're up to or follow your work, where should they go?
I joke that I'm a terrible millennial because I'm not on all the cool kid social media. I'm sorry, you will not be getting any TikToks from me. Or you know what? That's probably not even cool anymore. I don't know what popped up. Okay, the one that I keep up with is the med Twitter. So you can find me at RP Crowe. Or if you want to get on the adult Facebook and find me on LinkedIn, I answer those as well, though I'm not much of a poster.
Awesome. Well, we'll have those links available to folks in the show notes if you want to learn more, and well as I'll also be linking out to some of the original articles that inspired me to reach out to Remle about Ahora. And you can also go to the show notes and you'll find the graphic for Ahora right up there as well. So you can certainly download that and share that far and wide along with your BEFAST graphics so that more and more folks know how to recognize stroke to potentially save lives and minimize long-term disability. Remle, thanks so much for joining us this week. This has been great.
Thank you, Bill. This has been a blast. I appreciate the invitation.
I just want to say that I really had a blast talking with Remle. I mean, we ended up talking for a while before actually starting the interview, and then afterwards we continued talking on after that. Just a lot of fun and super knowledgeable. I love talking with folks who are also really into data and really sort of nerd out over the numbers, and that is fantastic. I mean, there are a lot of really fascinating takeaways in this conversation. I think, obviously, the first one that we hit on when we talk about the racial and ethnic disparities in stroke incidence and in type is that the most important takeaway from there is that these differences are not biological. These differences are societally driven. And of course, what that means is that there's nothing in the body itself that needs to change to bring those numbers in line. It's something we all need to do as part of a society to recognize these things and work on broader solutions, whether that's going to be education, whether that's going to be more listening to other communities, whether that's going to be addressing food deserts or the higher stress levels that many members of ethnic minority or marginalized communities live with, whether that's going to be faith in the medical system, whether that's going to be wealth or income distribution and all of these different things. These are all things that exist at the societal level, which have real world health impacts to people in our community. And that's something we need to keep in mind as we look at these numbers, as we look at this data, as we figure out what do we want to do and what kind of society do we want to live in going forward. I also have to say, I found the whole discussion around the emergency medical services, the ambulance service in Mexico, specifically in Mexico City, to be fascinating. I think it's amazing that Remle had that experience. When you compare and contrast that with, as she did, talked about the much shorter training period that paramedics and EMT professionals have in the United States as compared to what the professionals go through in Mexico City alone, that's a huge difference. But then just the scale of what we're talking about here. I mean, we have in the U.S. maybe we have a shorter training period, and maybe our EMTs don't see as many intense cases as their Mexican colleagues do in the same amount of time. But the scale and size of the service in the U.S. is just so much more effective, or at least for our communities, than in Mexico City. I mean, the idea that, as Remle talked about, that I keep getting hung up on is the idea of 6 ambulances operating in Mexico City on a good night. I mean, in a city of 25 million people, that's practically none as compared to the volume we have operating in the United States. And those are all things that are just fascinating to think about. And to talk about. And it's good to have that level of awareness and to know that Remle and her colleagues were able to do some amazing work and get some fantastic field experience, while at the same time recognizing that anytime an EMT gets fantastic field experience with an advanced technique, it's coming on the heels of somebody else's tragedy, where something in somebody else's life has gone terribly wrong. So it's so important to recognize just what it is our ambulance dwelling professionals are doing to take care of people in different cultures and different societies and different countries, and how dedicated they are to saving our lives and to getting us the care that we need. And that brings us to our hack of the week. But first, let's talk about our sponsor, Modus Nova. The Modus Nova device helps stroke survivors and others recover the use of an affected hand or foot. To get that limb back, we have to create new pathways in our brains because, our stroke disabilities are caused by problems in our heads, not actually in the limbs for the most part. And the way we create those new pathways is to repeat the desired motion thousands of times. The Modus hand and Modus foot help you do just that. They can move the limb for you when you have little to no ability. They can provide less assistance as you get stronger so you can continue to push yourself. And they can even resist your movement to help you get the most out of a workout. To learn more and see if Modus Nova is right for you, visit strokecast.com/Modus Nova. Save 10% off your first month with the promo code StrokeCast. And now, back to our hack of the week. Let's talk about hoodies. If you don't know what I mean by a hoodie, I'm referring to the light to midweight sweatshirt that has typically 2 big pockets up front, a zipper that goes straight up the middle, and, of course, a hood. And I have accumulated a whole bunch of these hoodies over the last several years. I've probably got about 10 or so that make their way in and out of rotation within my wardrobe at any given time. And I wore them occasionally before my stroke, but I find I'm wearing them a lot more over the years since my stroke. And they're helpful in a lot of ways. I mean, setting aside the obvious point that they help keep you warm, they also do have other benefits. For one thing, simply zipping it up is good practice. It may take several minutes or longer in the very early phases of recovery to get that zipper started, but if you keep at it, you may find you get some ability back. And it's one more way to add some additional exercise into your day of just playing with that hoodie. An unzipped hoodie gives you something you can practice on for your dexterity while you're sitting on the couch watching TV, or maybe even if you're sitting on a conference call someplace. It's a zipper that you can play with and practice with, and it's a heck of a lot more socially acceptable than some of the other zippers you might be wearing. The pockets on the hoodie are also really useful for, well, simply holding things. I mean, one of the things that happened after the stroke and the hemiparesis is that I could no longer reach the pockets on the left side of my body. I couldn't reach those pockets in my jeans. They essentially became useless. And once they did, I also did not have the extra hand that I could use to carry stuff. And even my unaffected hand, especially in the early days, was probably also going to be holding a cane. So having more pockets easily accessible became super important. And that's one of the other nice things about the hoodie. Sometimes my effective arm is being more problematic than others. Maybe it's that my tone is being super high that day, or maybe it's just extra flaccid for some reason, or it's just not behaving because I'm tired, or whatever's going on. Or maybe I've just hurt my shoulder and I want to give it a break a little bit and relieve some of the weight of the arm. What I can do is I can just stick my my left hand into that pocket in my hoodie to help sort of protect the arm, keep it out of the way, and to reduce some of the stress that's on my shoulder by just transferring it over to the hoodie. Another thing that can help is if you struggle with sensory overload, the hood on a hoodie can actually help block out some light. Maybe it can reduce your visual field in general and basically generally help with a slight reduction in external stimulus. A hoodie pulled up can also be a sign to others that you just want to be left alone for now and try to just reduce some of those other distractions and some of those other inputs that you just are not able to deal with at this particular time. I mean, in general, my girlfriend Kathy and I, we try to keep our home fairly cool. I suppose ideally it would be about 58 degrees most of the year. So I do find myself naturally gravitating to hoodies because they are so functional. But it turned out they help a lot in various things after stroke. If you don't already have a bunch of hoodies at your disposal, consider adding some of them to your wardrobe. Take a look and see what you can find. All sorts of great solutions out there. And that's it for this week. So head on over to strokecast.com/Ahora to review the mnemonic and to download the Ahora graphic that you can share far and wide. I'll also include a BEFAST graphic up there as well if you need to download one of those. Be sure to subscribe to the upcoming Strokecast email newsletter for free at strokecast.com/news. And share this episode with a friend, colleague, or heck, arch rival by giving them the link strokecast.com/Ahora. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you soon.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.